Yes, I will make a presentation of the Danish solution of collecting data from general practice. Denmark is a country with 5,005 million inhabitants. We are 3,600 GPs, and each doctor has about 1,600 patients. GPs in Denmark are independent. We have a patient list system. We are gatekeepers. I prefer to name it gate advisors. Patients do not pay for visiting the GPs. Most patients with chronic disease are controlled in general practice. General practice have a national contract with renewal every 30 years. The challenge, how can data for quality development and research be retrieved from different electronic medical record systems in Denmark? We have developed a data capture module. Here you have a practice. You have a practice system with a server and PCs, and we install a small program. And when it is installed, it starts collecting data, which is a copy of prescribing drugs, disbursement codes, laboratory analysis and results, ICPC diagnosis, and for some specific diseases or for research, it's possible to collect non-structured data as diabetes. Have you talked about the patient stop smoking? Have you talked about motion? And this data we are collecting in a pop-up screen, a questionnaire that pops up when the doctor has a contact with the patient. And all this data are sent for the national database every 2 hours. The doctor only has to register the diagnosis for his patient file. During the diabetes consultation, a pop-up screen automatically appears once a year, and the family doctor has to answer the questions in the pop-up screens, and it takes less than 2 minutes per patient, and he only has to do it once a year. All our data are automatically transferred from the electronic medical record system to the central database. Here you see the pop-up screen, and once you have to fill in the start year for diabetes, and if you have done it once, then the next year the pop-up screen come up, it is automatically filled in, and so you have to answer, it's in Danish. Have you made a food examination, and what do you find? And so on, and it takes about 1 or 2 minutes. You have to fill all in before this button shows okay. So it's a validation in the pop-up screen. Yes, you can press here and you say, I haven't time to fill in the pop-up now. And then the pop-up disappears. And when you turn out your computer in the evening, then the pop-up come up and say, you have to fill in these 2 pop-ups. Yes. And we also give feedback to the family doctor. He has access to his own data by using his professional digital signature. The following diabetes report is shown from the doctor's view. We have 38 different quality reports about different diseases, and they are available for the doctors. I've tried to show the diabetes report, a part of the diabetes report. Here you can see the reports for the doctors, some of the reports, and here you can see more of the reports. To look at these reports, you should make a code for all contacts. This practice are coding 93% of all doctor-patient contacts. And when you code this, you can see this report. And if you code less than 30%, then it's not possible to look at these reports. Here you have an overlook of your diabetes patients. You have 797 patients in your clinic, and 51 has diabetes. Here you can see the single patient, and is anonymized. And here you can see the HbA1c level, and the treatment of insulin or tablets, and the cholesterol level, and it's going down, it's going up. With a red arrow, it's going up, and green is going down. And you can see the albumin in urine, and if the patient receives lipid-lowering drugs, and if the patient receives ACE inhibitor, the blood pressure, and how many different tablets, drugs the patient receives for lowering the blood pressure, the body mass index, and the smoking habits, and the initials of the patient, the doctor who is responsible for the patient. Is it the GP who is responsible for the patient, or is it the hospital? And the birth months, and many doctors use the birth months to identify the patient, the patient who didn't come up for the annual control. And here you can see the last annual control, and it becomes red if more than 1 year has passed. Here is a benchmark you can benchmark you and yourself for 6 months ago. The red bar is the actual situation. The gray bar is for 6 months ago, and here you can compare with your doctors, your college in the municipality, and your doctors in the region, and the doctors in the national level. So about nearly 4% of all patients has diabetes registered in Denmark. And here you can see the level of HbA1c, and how many patients you have seen in the last year. And here you can see the treatment level, and here you can see the cholesterol level, and you can see you have a problem in your practice. The cholesterol level is higher than your colleagues in the national level. So you want to go back, and you press at the cholesterol level, and you can see it come to red over 4.5, and it's because the national guideline says if a patient has more than 4.5, he should receive lipid-lowering drugs. And you can see all the patients here should receive lipid-lowering drugs, and about 10 patients didn't receive lipid-lowering drugs. So you can identify the single patient, contact the patient, and start the medication. You can also press at the blood pressure, and then you have range to the patient with the highest systolic blood pressure in the upper part, and you can see here's a patient received 4 different drugs. Maybe it's difficult to get lower, and it's a home-registered blood pressure. But here you have a patient with only 1 drug. Here you can do it better. So it's possible to identify the patient where you can do it better. Here you can see it's a site for the patient. So it's possible for the patient to see that it's the blood pressure and it's the weight. That's a problem for the patient. And this the different tests that has happened in the last year. Patient also has access to their own data. and we have made it a little link. Maybe you can press the link. Oh. Oh, press the link here. Okay, you come to our home site, and you can see that in English version, and you can see some of our reports here. The reports are translated to English. Then please go back. Yes. Here's the site. It's in Danish. The patient also has a digital signature, and he can look at his own data by using the Sundhed.dk. It's a site where he should use his own digital signature, and he'd get access to his own data. Here's the Danish version of how do you, what do you see, and how to read the possibility. Here, it's the same site as that the doctor can see. It's a blood pressure, and it is a body mass index. That's the problem. It's in the red area. And if the patient wants to have more information about the blood pressure, he only has to press this button. Then he gets information of what is important with the blood pressure. We want to use this for the year control, because when we discuss with the patient, we discuss what's the risk of getting worse diabetes. We want to show the patient the risk factors that can be transferred. So we use the year control to discuss the patient, the goals for the coming year. What do you, the patient, what do you think you can reach for the coming year? The blood pressure, we can do it together, but the body mass index, maybe you should do something to minimize the body mass index. And these goals we are setting, the patient can go back 3 months after the year control. He said, what do I talk with the doctor about? What goals did we discuss? Then he can log in and look at his own data and see what he has discussed with the doctor and what goals he had set. Here you can see the goals he had talked with the doctors, and here you can see the optimal level of different HbA1c. You can see it's the first one. You can see it's 7.5. And why 7.5? That's because the patient had diabetes for more than 12 years, and you should regulate him down to 6.5, but 7.5. The risk is higher if you regulate him down to 6.5. So the computer, our database, automatically makes this optimal data. And you can see it here for the patient. It's the body mass index, and it's the blood pressure that is. Then the smoking habits, okay, he can stop smoking too. What advance do the family doctor obtains? He get an overview of his population of diabetes patient, especially patient with suboptimal treatment of the diabetes. He has a benchmark his performance with that of his colleagues, graph or results for discussion with the patient, and reports are updated every day for diabetes. The status is now 53% of all doctors in Denmark are using the system. 2.9 million patients are included. More than 100,000 diabetes patients are included. In April 2030, all GPs in Denmark must use the system. I think now Janus would show something about research.
Thank you very much. Yes, I would like to proceed with a very important question, which we have already addressed earlier in this conference. It is, does it work? Does it move anything for the patients? Does feedback improve diabetes care is one of the quality indicators we have been working with. And as Henrik just presented, we have a very large database because all Danish general practitioners are going to participate in time. We use data from 2009 to 2010, and at that time we had almost 500,000 patients included in the database, of which 18,500 patients were registered with type 2 diabetes. To look at the quality, we wanted only patients where the doctors had had time to look at their patients. So we would only include type 2 diabetes patient which has been seen twice for annual checkup with the doctors, which is registered in the database. So we looked at how is the single patient moved in 1 year from October 2009 to October 2010, with bearing in mind that the patient included in this project had to have been seen at least 2 times before. So the number of included patients was almost 8,000, and of the 8,000 with diabetes, we had recorded blood pressure of almost 6,000, and around 7,000 had recorded cholesterol levels. And as Henrik said, it's automatic subtracted from the electronic journals. So the proportion of patients with values above recommendations among the almost 8,000 included type 2 diabetes, we looked at the benchmark and how was the benchmark moved in this 1 year. So we looked at first diabetes control, the number or the proportion of diabetes patients who had a hemoglobin 1AC about 7%, but was not in any anti-diabetic treatment. And we saw in October 2009 there was almost 3% diabetics with hemoglobin A1C about 7% and did not receive any treatment for diabetes. And this figure was reduced by absolute risk reduction by 1.35% 1 year after to only 170 patients. If we look at the blood pressure, again it's a benchmark, it's the proportion of patients with systolic blood pressure about 130 and receiving no antihypertensive drug. And if we look at the figure in October 2009, it was 12.4%, and again we see 1 year later it was reduced to 7.9%. And for cholesterol, again it's a benchmark, it's the proportion of patients who has a cholesterol level about 4.5 and do not receive any cholesterol lowering medications. And it was in October 2009, it was more than 70% of the patient, and it was reduced 1 year later to 12.5%. So in all, we have a very huge improvement in benchmarking for the patients. One problem is that it might just be a general growing awareness of importance. We don't have a control group. So that's why I included this very nice slide from Campbell. Not to talk about pay for performance, but just to show that even if you get no incentive, there would be a better performance on quality indicators, just as well as if you get incentives, and this is English data. So we might have the same problem in our database, just putting a focus. It has nothing to do with the quality indicator itself, it could be underlying. there was a study using an earlier version of our report system, which was a randomized controlled trial. And it had 15-month follow-up. It's not data I have been doing, so I'm just presenting for one of my colleagues. It was with 86 clinics, 158 general practitioners, and almost 2,500 people with type 2 diabetes. So their results in short was that it had a very good effect on redeemed recommendation prescriptions, so that the patient would more often follow the oral anti-diabetic treatment, insulin treatment, lipid-lowering medication, and blood pressure medication. But sadly, there was no difference in mean glycated hemoglobin and serum cholesterol between the intervention and the control group. There might be a problem with too few patients, because it's almost significant, but there was no significant differences in this group. So there are some indications for that the quality indicators work, but we do still lack solid evidence, like it was mentioned earlier by Tina. So Henrik would like to continue.
It's from the practice in Denmark, how they work with the quality reports. They set goals in 3 areas, and it's important that all 3 areas are included. Goals for the clinic, goals for each doctor, and goals for the patient. You should have an overview over your own quality, as you have in the diabetes report. All staff members in the clinic must be involved. Work with setting goals. All must work with setting goals. And you should update the common knowledge in practice, so that the nurses and all are knowing about the quality. Introduction new routines in the organization, it's a very important issue. And monitoring the effort. An example, analyzes own data. The diabetes report shows that only 55% of the diabetes patients are measured with microalbuminuria at least once a year. The question is, can a target action increase the number of patients who are examined to 70% within a year? The process. Who is the coordinator and facilitator of the process? You must choose a member of the staff to be facilitator. Teaching involves the detection of microalbuminuria is important. You must teach so all have the knowledge. Guidelines for handling the test, the time for start and the time for follow-up, a deadline for reorganization of the task. And the organization, microalbuminuria exams becomes a part of the standard test for the annual control of diabetes. A nurse is responsible for studying the quality reports to find the patient who have not been tested, and for securing the follow-up. Patients should also know why it's important to get the urine tested for albuminuria. After 6 months, the proportion of examined patient is 73%, but a new analysis shows that we have not followed up on the pathological values. So we have to make a new project to ensure that all pathological values are repeated 2 or 3 times, and that you do what you should do. Exactly, the patient should receive an ACE inhibitor if they had microalbuminuria. Here you can see it in the report. It shows that something had happened from here to here. So the the message is you should keep it very simple. It takes time to build up a methodology and structure when working with quality development. Thank you.